recording, ready to go. I'm going to just quickly, I can't remember if I got to the paranasal sinuses or not at our last lecture. So if I did, this will be a quick review. If I did not, I'm just going to say a few things about when we say paranasal sinuses, para means around. So we're talking about sinuses found around the nasal cavity. They're all embedded in bones. I do remember telling you what a sinus is. A sinus is just an airspace or pocket or cavity that's lined with mucous membranes. So those sinuses are typically absent at birth, and then they develop in childhood. Typically, they start to form when our teeth first erupt, and then during puberty as well, and they grow, and that allows for expansion of the bones, as well as expansion of the head without adding significant weight to the head. The function is also sound resonance, and I did talk about that, I remember. And finally, sinusitis just means inflammation of it's inflammation of the mucous membranes in those paranasal sinuses. It can be caused by allergies, infection, even trauma or injury. So I'm going to call up my first whiteboard here and start with the next new topic, which are fontanelles. Fontanelles. Those, well, in street language, an easy way to think of those are the soft spots on newborn's head. But technically what they are, they're they're areas of unfused cranial plates at birth, and there's a fairly dense connective tissue connecting those plates, but it's allowing for growth of the bones and expansion as well. So the bones do eventually fuse, as you know, and develop into sutures. So I'm just going to draw an arrow like this and write sutures. That happens typically after birth. Sutures are just immovable joints. They're interlocking joints that look something like this. A bone on this side fusing with a bone on this side. There are major fontanelles. There's more than this that I'm going to list, but there are 6 major fontanelles that I am going to list and just say a few things about. I need to bring my iPad down where I can actually write legibly so you're not super confused about my writing. The first one's called the anterior fontanelle. Anterior means front, so we're talking about toward the front of the head. This is the largest of all fontanelles, so that's worth writing down. It's typically this oblong diamond shape. So I'm just going to write diamond. That means what shape it is. It kind of looks like, that means it kind of looks like this. This is specifically the fontanelle, the space. If we were looking at the top of the head, of a newborn's head, the frontal bone might come all the way up to past the hairline somewhere right here. The parietals, then, we're talking about the space between the 2 parietals and the frontal bone. And I should have left a slight point there. So the space of the anterior fontanelle is in here. And that's the one that we typically feel on a newborn's head because it is the largest and most palpable from the cranium. This typically fuses late as well. This fusion also takes longer in those, so I'm going to write that. Closes, I should write closes, not fuses. This fontanelle closes at about 18 to 24 months. That's just an average, a gross average. It's different for each individual. The next fontanelle is the posterior. It's not quite as big as the anterior. And that tends to be a sort of irregular shape. It's the rear side of the parietals back here. So I'm going to extend my picture. We've got right and left parietals. That would be the left, that would be the right. And the posterior fontanelle is between the two parietals and this occipital bone here. I'll write an O for occipital. So I'll use a different color. Here's the posterior fontanelle. So that one was yellow. This one was red. This one typically closes much sooner. It's rare to almost feel this one on the top of an infant's head. So closes at about 2 months of age. And then the next two fontanelles that I'm going to write are actually in pairs because they're on either side of the head, left and right. So they're on the lateral sides of the head. The first one is called the anterolateral. It's supposed to be an N. Anterolateral fontanelle. Antero means front or toward the front. Lateral means the side. So we're talking about in this area here. So it would be down where if you touch just in front of the upper part of your ear, it's in that area. So it's between the frontal and parietal bones on this lateral side, left and right. It also, the sphenoid bone, the very edge of the sphenoid bone also contributes to the boundary of this fontanelle. So parietal, frontal, and sphenoid. It's an irregular shape. It's not a diamond shape, and it closes a little bit later than a posterior, but not much, at about 3 months. And finally, the posterolateral fontanelle is just further back on the head on both left and right sides. That postero would be here on the side of the head as well as here. It almost merges with that posterior fontanelle. This one, you could say the lateral parietals, which means this area here, the occipital bone, and the temporal bones, which you cannot see on my drawing. They would be further inferior to that parietal. It's also quite irregularly shaped and closes it doesn't take as long as the anterior, but it closes at about 12 months. So in order of closure, this one's open the longest, then this one, then this one, and finally this one closes first, number 4, the soonest. The function of the fontanelles is to allow for expansion. I've already said that, of both bone growth as well as central nervous system expansion in the head. All right, let's go to a new board. I'm going to say just a few things about the hyoid bone. If you don't know, if you've never heard of that, or you don't know what or where it is, this is the only completely disarticulated bone in the human body. Articulation means not in connection with any other bone. Or articulation, sorry, literally means connected to another bone. This one is disarticulated. So no other bone comes into contact with this one. It forms no joints. It's basically embedded in tissue. So if this is the human head, and here's the neck, draw the chin of the mandible there. If you can feel your larynx, which is the Adam's apple. If that occurs, say right about here, the hyoid bone is between the larynx and the mandible. And I'll use a different color. It's horseshoe shaped, and it kind of is embedded in tissue like this. I've exaggerated its size. So it's a semi-ring that looks kind of like this as it comes toward us. And it thickens in this front area. It thickens in a superior, inferior, up and down sort of more than it does in anterior, posterior. And it has little horns on it, or bumps, that are attachment points for tendons of muscles. Its main function is that it anchors muscles of the tongue and some neck muscles. Most of the tongue muscles are anchored in some way to the thyroid bone. So what it does is it supports our ability to manipulate our tongue. Obviously, that helps us with speech. Now let's move on. Since I have so much white space here, I am going on to the vertebral column. I'll try to give you as many facts about this as we have time for. So the vertebral column is made up of 26 total bones, 24 vertebrae. That's not in addition to, I mean, included in that 26 number are 24 vertebrae, 1 sacrum, and 1 coccyx. I'll talk about each of these individually. You and I typically refer to it as the spine, but I'll try to stick with the scientific language, which is vertebral column. There are three major types of vertebrae. Most of you have heard this language. The first, cervical, which are in the neck. That's why we learn this language the first week of class. There are 7 total cervical vertebrae. The second major type are thoracic, which just means chest. So in the thoracic cavity, there are 12 total vertebrae. And finally, lumbar. I know most of you have heard this language. There are 5 total lumbars. So there's 24 when you add those up. There's all sorts of different features to these. The thoracic vertebrae are the only ones that articulate with our ribs. So we have 12 total thoracic vertebrae, and therefore we have 12 pairs of ribs that articulate with those on the back side of the body. Now I'm going to briefly talk about just some general characteristics of the spinal cord or the vertebral column. So I'm going to call up a new page. Let's look at the curvature. This is normal curvature of the vertebral column. I'll exaggerate it a tiny bit so you can actually see it. If you were looking at an individual person from a lateral view, aka from the side, the the vertebral column would look like this. There's a slight concave from the back, convex, concave again, and then convex. So this repeating S-shaped pattern is what a normal curvature is like in a healthy adult. The cervicals, we call this, depending on what side you look at this from. I just gave a lecture this morning to another AMP1 class down in Rowan, and they called this a convex curve because that textbook looks at it from the anterior side. From the posterior side, that would be a concave curve. And I think that's where your Marie book examines those curvatures from. So the concave, convex, depends on what side you're looking at. These would be the cervicals up here. The thoracics would be in this region, and the lumbars down here. This is referred to as the sacral curve and coccyx, sacral and coccyx curve down here. There are abnormal curvatures to the spine. You've heard some of this language, I'm sure. So that's a lateral view. From straight on, anterior, posterior, the vertebral column looks perfectly straight. So if you were to look at somebody from the backside or from the front, their vertebral column, if normal, would be straight. Now let's examine a few abnormal curvatures. I'll write down the names and describe them for you. Number one, I think this is the order of your book. If not, it doesn't matter. There's only three. It's pronounced kyphosis, Kyphosis. Kyphosis refers to an abnormal curvature in the thoracic vertebrae here. Okay, so, and it's an exaggeration. There's different causes of this abnormality. It's fairly common in the elderly to develop kyphosis, or an abnormal curvature of the thoracic vertebrae, and it pushes that curvature into an extreme. You've seen older people who are sort of hunched over. That's typically due to osteoporosis. But the causes can be not just bone degradation. Second abnormal curvature is lordosis, Lordosis. That would be an abnormal curvature or exaggeration in the lumbar region down here. So we get sort of a swayed, what people call swayed back. It's an exaggeration of this lumbar curvature. Sometimes people are just congenitally born with this. Other times it's developed from some sort of bone abnormality or disease or injury. And finally, number three, scoliosis. This is a bit different. It's not an exaggeration of a normal curvature of the vertebral column. It is an abnormal lateral curvature. If you looked at somebody from the front or back and they had an abnormal curvature, say in their thoracic region, or perhaps an abnormal curvature in their lumbar region, that's scoliosis. And it needs to be evaluated it's visually evaluated at first, usually by a pediatrician, by asking a child to bend over with the physician, he or she being directly behind the patient, evaluating that curvature. Now I'm going to say a few things about intervertebral. Sorry about that. It's INTERVERT, intervertebral discs, what you and I call the discs in the back. These are pads or cushions of cartilage that exist between the body of each vertebrae. I'll draw you an anatomical drawing of a typical vertebrae after we get to specific vertebrae. So let's talk about these discs. These cushions or discs make up about 25% of the full length of the vertebral column. I'm just going to write VC for vertebral column. I'm going to cross-section a disc for you first. So if we look at a disc, it's roughly kind of circular shaped like this. There is an outer covering as well as an inside, and they're both tissue. That's not a hollow space in the middle of the disc. It's just two different types of tissue. The outer tissue is mostly fibrocartilage, and it acts as a containment type of function for the inner softer tissue. We refer to the fibrocartilage outer part as the annulus, ANNULUS. The inner portion is a softer, I'm going to use green. I was going to use red, but I don't want you to think it's blood because it's not. It's just a softer tissue. So I'm going to write inner. That's referred to as the pulposus, and I'll write that name in a minute. This is softer tissue, so I'm going to write soft, and it's very elastic. And its scientific name is PULPOSUS, pulposus. all of these discs, let me go back to my black, are avascular. So there's no direct blood supply. I'm going to give you a quick lateral view. If this is a vertebrae, there's the body of it. Here's transverse process and then a spinous process. The discs would sit between two vertebrae. There's the body of the one inferior to it. There's the next spinous process. And the disc would be in here, intervertebral disc. It provides obviously shock absorption and cushioning every time we take a step, run, or jump, but it's completely avascular. Well, the body of the vertebrae are highly vascularized, lots of blood vessels, especially in this body portion where there's lots of spongy bone and red marrow. And that's where the disc gets its nutrition. The cartilage for both the annulus and pulposus get their nutrition by diffusion from the vascularization actually in the bone and the vertebrae itself. Let's do some simple anatomy of a disc. This is a very crude drawing I'm going to do. It's just the basics. Solid, oops, let's try to do black here. The solid portion of a typical vertebrae. This is a bird's eye view. It's not the lateral side view that I just drew. There's a solid body portion, and then the structures kind of do something like this. I'm drawing it purposefully this way so you see how this is actually how the bones form in utero as I'm drawing it. And there's spikes or processes coming off of it, of the vertebrae. Once again, this is a bird's eye view, not a side or lateral view. So there's a typical vertebrae. This is solid bone in here. That's called the body. That's where the spongy bone is and all the blood supply, the red marrow. And it is a place sometimes where patients get tapped for a marrow transplant, although that usually occurs in the ilium of the pelvis of the hip. I'll explain that when we get to the pelvis. The bone forms like I drew it, creating this circle or big foramen in the middle. This is called the vertebral foramen. And when we stack vertebrae on top of each other, it creates a canal for the spinal cord to run down through the vertebrae. The pedicle, pedis means foot, so I drew a ring around what's called the pedicle, and that forms in utero and fuses with this area out here called the lamina. And you can see they make a bridge that's called the vertebral arch. So when we fuse this part of bone tissue with this part of bone tissue, we create this arch that is called the vertebral arch. And it actually creates then this foramen, this hole. These processes running off of here, there's two transverse processes that sort of point out, depending on the type of vertebrae, they emanate in a posterior and left and right direction. So that would be one transverse process. Here's the other one over here. I'm just going to write TRANS to save space. Process. And finally, the spinous process. That's the one that sticks off in a medial posterior direction from the backside. There are a few other that's the gist of it. That's the main anatomical features. And then there are, depending on the type of vertebrae and the location, there are bumps, tubercles, as well as facets. I do want you to become familiar with this word. A facet is an articular surface, sort of a smooth, articular surface. So we find facets on almost all of the vertebrae. A facet enables that vertebra is singular, enables that vertebra to articulate with the vertebra above as well as below. They're difficult for me to draw. In this typical example, they sort of come off of the pedicle here like this. There's superior and inferior facets that articulate with the bone above and the bone below. So that's the general anatomy of this. Now a lateral view, I'll try to be quick with this because I want to get to a lot of other things. There's a vertebrae from the side, a lateral view, and then we have a space where the disc would be, and then another vertebra. When this vertebra articulates with the one above at facets, say here and here, those typically, the connection, some of those articulation points create a canal or foramina, a hole in typically right here in this area. So if part of this bone articulates with another part of this bone, we create this canal or cavity, and spinal nerves emanating off of the spinal cord use this space to come off of the spinal cord and out into our appendages. They're called intervertebral foramen. So I'll write that. An intervertebral. Some books call them foramina. That just means small hole. And that's where spinal nerves can exit and run out into our appendages. All right, we've done the general anatomy, which was good. The gist, I'm just making sure I covered all of this material up here that I wanted to, and it looks like I did. So what does age do to the vertebral column? Well, it's usually a site of almost exacerbated osteoporosis. So as we age, most of us acquire what's called osteopenia, which is the normal thinning of our bones. And one of the most afflicted areas is the vertebral column. That's the degradation, the lack of collagen, as well as the degradation of bone mass from osteoclast activity as we age. So the vertebrae in particular are really susceptible to osteoporosis. Okay, so say a few things about the sacrum and coccyx, then we'll move on to the thoracic cavity. So I'm just going to write sacrum, that's an A. This is at the base of L5. So if we have that really big lumbar L5, the vertebrae get larger as they go from cervical to lumbar, by the way. The reason is because they have to bear more and more weight on top of them. Lumbar vertebrae are big, have big, huge, solid bodies, and these sort of sharp, blunt spinous processes like this. So that would be a lumbar. A thoracic vertebrae has a smaller body mass, larger transverse processes coming off both sides, and a characteristic long, sharp spinous process coming off the back. So that would be a typical thoracic. And then a cervical, they vary from C1 down to C7. They vary greatly in shape. In other words, C7, which would sit right on top of T1, almost looks like a thoracic. It's hard to tell the difference between the two. I'm going to talk about specific cervical vertebrae in a moment after I talk about the sacrum. So this is L5, which is the last lumbar vertebrae, and the sacrum sort of looks like this. There's an articulation. It's got these, it's sort of triangular or heart-shaped. The sacrum is 5 fused vertebrae. So when we are in utero, those vertebrae are not yet fused. They typically don't fuse until fully fuse until about late in our teens, age 16 to 18, do these vertebrae actually fuse. And the coccyx, which is the tailbone, is a separate bone down here. That's typically 4 vertebrae. It varies from individual to individual. I'm going to write 3 to 5 fused vertebrae. And those fuse even later. I think it's usually right around age 20, but it can go well up to almost 30 years old. So about 20 to 30 years, those fuse. These fuse at about 16 to 18 years. The fusion process into a suture. There would be a suture here, here, and here. Those sutures fully fuse at about those age ranges. I'm going to draw, as best I can, I'm going to draw some typical features on the sacrum. So I'm going to draw a new sacrum over here. This is an anterior view. So if you were looking through somebody's abdominal cavity at the sacrum, we have a shape that kind of looks like this. You can see ridges where the fusion occurred. They're called transverse ridges where those vertebrae finally fused. And then there are large, fairly large holes or foramen, and they call them foramina in this case, although when I look at sacral bones in lab, they are quite large. They're called sacral foramina. Vessels and nerves typically run through these holes, these foramen. The sacral promontory is a ridge of bone up here at the top. So I'm just going to write promontory. These wings, I exaggerated them in my first drawing, but these wings left and right, they almost look like ears, are called, singular as ala, ala. If we put an E at the end of it, that's plural, ali. So there's 2 ali, one on either side of the superior lateral surfaces. These fusion regions, sutures, are called transverse ridges. They're just where those 5 vertebrae eventually fused. And if we look at the backside, I'm just going to add a feature onto the backside. We see facets on the posterior side, a canal. So we see a couple facets and canals up toward the top. I'm probably going to run out of space here pretty soon. It'll cut me off. There's a ridge of bone running down the middle of the posterior side of the sacrum. That's called the median sacral crest. That is remnants of the spinous process of those fused vertebrae, individual vertebrae. So these are actually, they look like individual bumps. 1, 2, 3, 4, 5. And that makes up the median sacral crest. So if I ask you on the next lecture quiz, how is the median sacral crest formed, or what makes up the median sacral crest? It's the spinous process of individual vertebrae that have fused. So I'm going to write spinous processes. And finally, the only other thing I'm going to identify is something called the auricular surface, and I'll use this side. There's a rough surface on the posterior lateral side of each ala or ali called the auricular surface, A-U-R-I-C-U-L-A-R. That is the surface that specifically articulates with the ilium of the pelvis. So it's called the SI joint or sacroiliac joint. That occurs out here with part of the pelvis. And this surface is the actual articulation surface for that. We're not going to say a whole lot about the coccyx other than 3 to 5 fused. It doesn't have a real serious function. It does anchor some ligaments and some tendons of muscles, but by and large, the coccyx is practically dysfunctional. It's called a vestigial tail because we humans don't really need it. All right, let's say a few more things about individual ribs. So I'm going to go to thoracic cavity or thoracic cage. We have 12 pairs of ribs. That lines up with 12 thoracic vertebrae because that's what they articulate with. So we have 7 cervicals, no ribs attached, 12 thoracic vertebrae, all ribs are attached to those, and 5 lumbars. The ribs, some of you, I'm sure, are aware of this, some of you might not be. The ribs actually articulate specifically bone to bone on the back side at the vertebral side. And then, so if I draw, I'm not gonna draw all 12. So here are some bodies of thoracic vertebrae. The ribs articulate back here and then come forward at an angle like this. And then the bone actually ends. Ribs, by the way, are considered flat bones. Even though they have a curvature, they're flat bones. And there's actually an articulation surface here with the vertebrae. And then as those ribs come forward, there is no bone-to-bone articulation with the sternum. That connection is made via hyaline cartilage. That's called costal cartilage. And then there's a sternum. I'm just going to quickly draw a sternum here in front. I'll talk about the features of the sternum in a moment. So the key to this little drawing is bone-to-bone articulation back here. This is bone, cartilage bone connection on the anterior side in the front. And an individual rib, we can identify which end, even if I took, say, this rib out of the body, I could easily identify which end is vertebral end and which end is sternal end by not only the shape of the curvature. So I'll do that right now. The ribs back here at the articulation end, there's a sharper curve, and then they sort of flatten out like this. They almost make a hook shape. Also at the vertebral end, which is called the head of the rib, there are tubercles and facets to articulate with the actual vertebrae itself. And then the flat bones comes forward, and it literally looks like it was cut off like this. So we can always tell the vertebral end by the presence of these tubercles and facets, and we can tell visually the sternal end by it literally comes to an end. It looks like you just cut it off with a pair of scissors. This very neat perpendicular cut. Costal cartilage is hyaline cartilage, the type of tissue. And it makes this connection with the ribs to the bones, but not all ribs share the same type of connection. So let's discuss that briefly. Pairs, because there are 12 pairs, there's 24 total ribs in the human body. Pairs 1 through 7 of the ribs are called true ribs. The reason they get that distinction is because they have their own individual costal cartilage connection to the sternum. So I've drawn 3 true ribs in my picture. Pairs 8, this is confusing. I'll try to explain it. Sometimes it's confusing. Pairs 8 through 12 are called false ribs. Let's start with 11 and 12. Within this category, pairs 11 and 12 are floating ribs. They have no connection to the sternum whatsoever. So pairs 11 and 12 are considered floating. And so what I tell students usually in class is pairs 8, 9, and 10 are really false ribs. And what designates those as false is they share one cartilage connection to the sternum. So pairs 8, 9, and 10 are what I call really false ribs, and they share a common costal cartilage connection to the sternum. So in closing here, pairs 11 and 12, I'm going to draw vertebrae. Pairs 11 and 12 articulate with the lowest thoracic vertebrae, but they stop short. They hardly have a curve to them as well. They stop well short of the sternum, and we call them floating. Technically, they have a cartilage connection, but it's just embedded in soft tissue. And then pairs 10, 9, and 8, they articulate with, as they come forward, they share a costal cartilage connection like this. It merges to become one connection to the sternum. That's why they're called false. All right, I'm going to say a few things about the sternum. We'll define the anatomical areas of the sternum itself. It's sometimes called the breastbone. It is shaped somewhat like this. There's this heart-shaped piece at the top, and then a very long vertical section, and finally a really small pointy section at the bottom. So there's three major divisions to the sternum. The top one, the first one, is called the manubrium. It's kind of a heart-shaped bone. They are three separate bones that eventually fuse. On the manubrium, there are some anatomical features worth noting. The first two are called the clavicular notches, here and here. Those depressions in the edge of the manubrium get their name because that's the articulation point of the clavicles, the collarbone. So we have two clavicular notches. They're sort of right and left. And right in the center, and this is a very prominent feature, and you can feel this on yourself right now in your neck. That depression at the base of your neck, right in front, is called the jugular notch. Gets its name because the jugular veins that drain deoxygenated blood from the head back to the heart sort of do that in this area. They don't. So the jugulars would come down either side of the neck. Anyway, that's where it gets its true name, the jugular notch. Not going to talk about the clavicles just yet. Before we leave this lecture today, because I'm splitting chapter 7 up into 2 weeks rather than, and we're going to do one exam on that, I'm going to stop a little bit short today. But before I stop completely, I'm going to talk about some abnormalities or medical conditions that I think is worth noting and worth you learning. This term, since we're talking about the ribs and the sternum, costochondritis. Let's just examine this term. Itis means inflammation of, chondro means cartilage, costo means ribs. So we're talking about that hyaline cartilage that connects the rib to the sternum and inflammation of that. Typically, let me go back to this diagram. Typically, costochondritis and inflammation of that cartilage really is some sort of damage to this connection. It's fairly common in some athletes, and it causes inflammation and pain, obviously, but this is a somewhat vulnerable area of connection. Baseball players, it's common if they swing a bat too hard, the muscles sometimes are stronger than that connection, and they can pull that connection ajar so that it looks something like this. It can sort of misalign this connection. Typically, it heals on its own with lack of movement, rest, anti-inflammatories. Occasionally, it can be so severe that surgical intervention is necessary. I'm going back to my sternum page. So that's costochondritis. Ribs do break, obviously. People suffer broken ribs, particularly elderly, whose bones are brittle, and now you know why. The middle ribs, so ribs, say 5 through 8, are more vulnerable. It's more typical to break those ribs than the other ones because of the shape that the thoracic cavity takes is sort of a cone shape like this. And those middle ribs stick out further and they're more prone to trauma. When a rib breaks, it's extremely painful. I've luckily never had that happen. I have had costochondritis though, and that's painful enough. Typically ribs, we don't immobilize a case of a broken rib anymore. At one time, that was common practice to tape up the thoracic cavity and let the bone heal from immobilization. Now we don't do that because there's a high risk of pneumonia in those patients, and those ribs need to expand and contract in order to prevent fluid from building up in the lungs and infection. So also a severe broken rib, if it's displaced, it's a compound fracture or displaced, like completely displaced like this, can be very dangerous. These broken ends of ribs can puncture major vessels to the cardiovascular system, the renal system. It's of serious concern. A herniated disc, now that you know all about intervertebral discs, a herniated disc usually is it can be from trauma or injury or compression. So we have a bone on bone, and these discs can get squished and cause them to bulge outward like this. It's not only the disc bulging outward that is a serious problem. Let's take a quick cross section of this disc, the annulus. So the annulus fibrocartilage not only gets, and I wanted to use blue, gets distorted and squished outward. But during a herniated disc, the nucleus part of the pulposus protrudes through that herniation. Sorry, I wanted black, like that, as such. So we lose some of we get a bulging of this fibrocartilage, and also a forcing or losing of nucleus material of the propulsus going out this way as well. That can be very painful because that can impinge or pinch a nerve along the spinal cord in this area, or emanating from a spinal cord like this. Typical procedures to deal with this that orthopedic surgeons use is they go in there with a scalpel into the space, and they literally scrape off this herniated portion. Also, a fusion might be in order. If this disc right here is so herniated and so distorted and so compressed that there's not much left of it, surgeons can sometimes perform a laminotomy, a fusion of those. A laminectomy is actually something else. I'll talk about that in a minute. They can fuse these two vertebrae together either with screws or by grafting on some sort of inorganic material to keep those immobilized. Really fast here, I'm going to do some other medical conditions and then we'll be finished. A laminectomy, which was on my mind, I'll describe that. Ectomy means that suffix means removal of, like appendectomy, removal of the appendix. We're going to remove, or a surgeon removes, part of the lamina. So here's our vertebrae, transverse, spinous, transverse. Here's our vertebral foramen. A surgeon may need to get into this space to perform some sort of procedure, and so a removal of this lamina is called upon in order to do that. That's, if you hear these terms, laminectomy, literally a chunk of the vertebrae of this arch, vertebral arch, is removed for surgery purposes. Something called a lumbar spine stenosis. Stenosis means narrowing of or compression of, so narrowing of the spinal canal. Last but not least, this is the last one I wanted to bring up, spina bifida, something you may have heard of. This is a congenital disorder. It means we're born with it, or people who are afflicted with this are born with it. And I'm going to use my vertebrae picture to describe what goes on during spina bifida. When we are in utero, before we're born, the pedicles down here in utero fuse with the lamina up here to create this vertebral arch. In the case of spina bifida, that fusion to create this arch is incomplete. It doesn't happen correctly. And so we end up with a vertebrae or a number of vertebrae that sort of look like this, that may look and that leaves the real trouble with this. It leaves an open cavity here and central nervous system tissue. I'll draw that in yellow. In here, that's the spinal cord. Central nervous system tissue can get out. And during growth, during development, it bulges outward. And in the most severe cases of spina bifida, the child is born with this big lump in the lumbar area of their spine, and that's all neural tissue. It can cause paralysis and loss of urinary or bowel function as well. There are variations on spina bifida, meaning the degree to which this is malformed in this area. If there's a huge gap here, it's very serious and surgical procedure is necessary almost immediately. In some individuals, this fusion just falls just a little bit short. And in those cases, it's not nearly as severe. The person is almost 100% functional, and the only evidence of it really is a small depression on the backside in the lumbar area of that person. All right, guys, I'm going to cut it there. So let me stop recording.